welcome to this webinar organized by the European Haemophilia Consortium in cooperation with EAHAD and dedicated to the management of hemophilia B with inhibitors. Although we all have witnessed significant advances in treatment over recent years, hemophilia B with inhibitors remains a particularly challenging condition to manage. Many people living with this disorder continue to face daily difficulties, from managing recurrent bleeding episodes to dealing with their long-term consequences. Today, by bringing together both patients and clinical perspectives, we hope to foster a meaningful exchange that may contribute to further improvement in care and management. My name is Stefan Radovanovic, for those who don't know me, and I'm the Patient Engagement and Community Lead at the European Haemophilia Consortium, and I will have the pleasure of facilitating today's discussion with two distinguished speakers of ours. Our first speaker in order of appearance is Dominik Čepić from Croatia. Dominik has been a dedicated member of the hemophilia and bleeding disorder community in general for many years and lives with hemophilia B with inhibitors. He's also a member of the ERIN committee, and we are grateful to him for sharing his personal experience with us today. Our second speaker is Dr. Elisa Mancuso. For those who may not know her, Dr. Mancuso is a hematologist and senior hematology consultant at the Center for Thrombosis and Haemorrhagic Diseases at IRCCS Humanitas Research Hospital in Rozzano, Milan, Italy. And she's also an adjunct clinical professor at Humanitas University. The HC is honored to have her as a member of the ERIN committee and as chair of the EHC Medical Advisory Group. So without further ado, I would like to invite our first speaker, Dominik, to take the floor and share his experience. So please, Dominik, the floor is yours.
Hello, ladies and gentlemen. My name is Dominik. Thank you, Stefan, for the kind introduction. I will keep the introduction short this time. So I have severe hemophilia B with inhibitors, and I will start from the beginning of my timeline. From my diagnosis from my childhood. I was diagnosed with severe hemophilia B when I was 6 months old in Zagreb, in Croatia. They put a needle in my little finger back then. They tried to pull out some blood, but the bleeding could not stop. So after going through a lot of tests, they finally detected that I have severe hemophilia B with inhibitors. Inhibitors didn't show back then. They were non-existent, but after my first dose of plasma-derived factor IX, I felt into an anaphylactic shock, and after that, I couldn't get rid of the inhibitors. So my diagnosis started from a really, really young age. Throughout my whole childhood, I had really bad and severe bleeding episodes. In a month that has 30 days, I would be in a hospital for 29 of them. Often situations happened that I was still in the hospital. I was receiving my blood clogging therapy, and I still got other different bleedings. I go into the hospital for a fist bleeding. I come out from the hospital with a shoulder or an elbow bleeding. So after years and years of that, I somehow thought in my head that this is just the way it is. This is a normal life for me, and this is standard, receiving therapy that's supposed to help me, that's supposed to save me from the hospital, but somehow it doesn't help that much. And for months and months, for years and years, it functioned like that. Hospital visits became a normal, everyday part of my life. me being in the hospital, hospitalized. That was a normal part of my life as well. My hospital, Shalata in Zagreb, and now Rebro, was my second home, I would say. Sometimes even my first home, because I was more there than at home. My parents had to be very careful with me. They protected me as much as they could, but that helped a lot. I would say, I cannot say that didn't help, but I had a lot of spontaneous bleedings. I lay down in the evening healthy, and I wake up tomorrow morning without any trauma, with a bleeding. And that happened so often that I had more spontaneous bleeds than traumatic ones. And the percentage, I would say, would be 80 to 20%. So that's kind of a lot. Hemophilia B with inhibitors, I heard, is kind of specific with that issue, I would say. And maybe Maria could confirm or deny that after me. So I couldn't do a lot of activities as my peers. I couldn't play soccer. Now, World Football stage, World Cup is going on. I couldn't play any sports. I could only play chess, I would say, from the sport perspective. And often I felt excluded with my friend group, even though my personality helped me a lot to override that part. I faced a lot of challenges growing up, really a lot of challenges. I had 600 hours per school year that I was out of school. Some parts of my life I was even homeschooled. I had a lot of painful bleedings, especially in my right shoulder and my right elbow. I think bleedings in those joints were one of the most painful ones, and that those bleedings, unfortunately, couldn't be stopped. Couldn't be stopped, easily speaking, because even with the therapy I received back then, bleeding episodes would last for 3 weeks, sometimes even 4 or 5 weeks, especially in bigger joints as shoulders. In those cases, rarely, when my inhibitors went down, I could receive factor 9, but I would say that was possible maybe once every 3 years, because inhibitors took a lot of time to go down. So every 3 years, I had my specific therapy that I should have received from the beginning, but I couldn't because of the inhibitors. And then it really helped. It really helped. I felt cured for those 1 to 2 days when I received it. But after that, it all fell apart because my inhibitors went up and I couldn't receive the factor 9 treatment again. And then I was back. I was back on the supplementary treatment. So I will go back to the primary school and those 600 plus hours of skipping it. I mean, it was hard. It was hard dealing with all of the problems hemophilia throws at your face in those cases, and everyday stuff like going to school, hanging out with your friends back then, and even through high school when I was homeschooled. I didn't really go out much. I didn't really have time because my illness didn't give any time for me to use it properly. I would say at that time I was going through puberty and bleeding episodes, everything that hemophilia presents, everything that hemophilia B has to offer, that just tripled in intensity. When I was younger, before puberty, I was 29 days with bleedings out of 30. And in puberty, I was 36 days out of 30, if that's possible. You know what I want to say. But sometimes even I had 6 bleedings at the same time that couldn't be stopped with any type of treatment. So sometimes doctors didn't know what to do, so they even didn't give me none. You know, I totally understand. Everybody was just trying to find the right and best way how to approach this situation. I didn't know how because I was really young, and back then the only thing I knew was pain. My parents didn't know because nobody educated them at that point in their lives. And conferences, webinars like this didn't exist back then. Doctors didn't even know because I was the first and only case Croatia has seen, maybe ever at that point. So yes, my life my life because of that was shaped with hemophilia B in the first place, and everything else in the second place. Often there was cases that I couldn't walk for 6 months, for half a year. I couldn't stand on my feet because of constant joint bleedings. I had even severe bleedings in my organs, my kidneys, inside of the intestines, and etc. I don't think there was a place on my body that I didn't bleed out of. So is that some kind of a record? I don't know. We need to ask Guinness, but I will talk to Stefan after this webinar about that. Maybe we can figure something out. So yeah, especially in my puberty time, it had an impact on my emotional well-being, on my psychological well-being. I know back then I was in a severe depression for some time, maybe even 2 years, because of everything that was going on in my life. My school was on hold. Everything was kind of on hold. Everybody just wanted to save me, and nobody knew how. Or they knew, but they couldn't because there wasn't a possibility for that. So hemophilia impacted my life on a lot of fronts than only bleedings, than only pain. Pain was the most important everyday part, but there was a lot of things going on as well with it. Because pain, when it's constant, when it's every day, you learn how to live with it. You know, it just becomes normal. Your shoulder hurts. Okay, it hurts for 30 days. You don't feel it anymore after 31 days after that. But you feel everything else, you know. You cannot go out of your house. You cannot stand on your foot. You cannot go to school. And almost in every sentence, there's something you cannot do, you know. You really rarely hear something that you can. And that leaves a big impact on you, especially when you're young. Well, I'll talk from my perspective at least. So I lived like that for 17 years. Until I was 17, I had the same treatment, the only one that existed back then. And after a bleeding episode that lasted for 4 to 5 months, I would say, in my right shoulder, that was unbearable, to be honest. For 4 to 5 months, I couldn't sleep. The only way I could have fell asleep is to fall unconscious, literally, from being so tired, so tired. No, I don't think any type of pain medication helped me at that point, at least any type that I could receive. They still didn't put me on hard drugs at that point. So nothing could help. And one day I went to the hospital, and my ex-hematologist, that's now retired, she told me that there's a new experimental treatment that's now on trial in Europe, that's proved really good with patients with hemophilia B with inhibitors. And she asked me if I want to be a part of the trial, that she thinks she can get me into the trial, and she asked me if I will be willing. Almost immediately, I said yes, without any information, without reading any contract or anything at that point, because, well, I don't know how to put it lightly, but I don't think I lived my life back then. I don't think I was kind of alive, if you understand what I want to say. Because 17 years of constant bleedings kind of, yeah, in that perspective. So I immediately said yes, and she immediately got to work on that. And in the span of maybe a month, she got medication to Croatia, and I've signed all of the million bajillion contracts that I needed to, and read through everything. Everything looked good, really professional, exceptional even. And they gave me the first loading dose. They called that back then. At that point, I still had that 4 month to 5 months bleeding active going on. I think almost immediately that evening, after receiving the loading dose, I've started to feel better. The joint that was 3 times the size, the usual size that it's supposed to be, started to swell down. And from that point onwards, from 17 to now 26, things have really changed for the better. I think the new prophylactic treatment I received back then when I was 17, it really saved my life. In the beginning, I had much less bleeding episodes. How the time progressed, there was less and less of them. I started to be more confident. I started going to school. I signed up for college. My quality of life went through the roof, absolutely through the roof. I was finally able to work and to function like a normal human being. I finally was able to be independent, I had the freedom to plan my life how I wanted it to be planned out. I climbed my first mountain back then. Even though everybody suggested not to, first time I went on a jet ski, and everything crazy young people do these days. For me, that was crazy to even think about that. But after that, the feeling to know it's not crazy, and the feeling you have to see that you can do that, and to not have any repercussions, to not be home with a bleeding for 7 days in the bed, that was the most amazing feeling in the world back then. And to be honest, it shaped me in a person I am today, because of everything I know how was back then and everything I know how is right now. After that, you just have to appreciate the life you have in front of you, and live it to the fullest, to the full ability that you have. I know I'm probably over time, but I will try to. I want to talk about a few other things. my hospital, all of the hospital workers, hospital professionals, doctors, especially doctors at the later stage when I was a little bit older, when I knew how to approach hemophilia, when I started to talk with the doctors about it. When not just my parents talked with them, I started to talk with them. They really helped me go through this whole period. They were my second family, I would say. They knew all of my problems. They always tried to help me with their best ability. And without them, without whole hemophilia community, without Croatia Haemophilia Society, without this big family, without this that we're creating today, all of us together, I think maybe this all would be possible. This new medication, our togetherness, our fight for everybody's greater good. But it would take years longer than it is right now. That is my honest opinion about that, and that's what life showed me, unfortunately. So today I'm working in sales. I have a full-time job. I have a beautiful girlfriend. I have really rare bleeding episodes, maybe once every 3 to 6 months, depending on how I take care of myself, of course. I'm traveling a lot. I just love meeting new people every day, and I'm living life to the fullest, trying to make up, I guess, those 17 years of bad luck. In short, in really short, I think I could be here sitting and talking about this until Christmas. But in short, I mean, hemophilia will always be a big part of my life, and it will always be a part of who I am. It built me in a person that I'm today, but it doesn't define me. With proper care, with the help of the healthcare professionals, with new medication, with new treatment, and with everybody here in this Zoom call, I think we can make lives of hemophilia patients really high quality. We have a big opportunity here. We really did a great job up until now, and it's really important to continue working on it constantly. Maybe sometimes if we're all boring to each other, we need that togetherness. We need to fight for each other, because I know sometimes I feel great. There's maybe no reason that I'm here talking about this. Some people may feel like that, but we just need to take care for each other. And I know there's a lot of people that still don't have proper treatment. I know I was that person back in the day, but it really changed my life. And for that, we need to fight together, really, so we can all build our lives how we want them, and not to be controlled by something that we can work on. We can even cure. We can even cure, or if we cannot cure, we can really help our lives to become really maybe the same as a person that doesn't have hemophilia. Maybe not now, but one day, possibly. So I'll finish on that positive note, I guess.
Thank you. Thank you so much, Dominic, for sharing your very impactful personal experience. It's always enjoying listening you. So just a brief reminder to everyone in the audience, please hold your questions until the second part of the webinar, when we will open the floor for an interactive discussion. I will now invite Dr. Maria Elisa Mancuso to provide the clinical perspective and share her experience in treating hemophilia B with inhibitors.
Thank you, Stefan. And first of all, thank you, Dominic. I think you really summarized very well what is hemophilia B with inhibitors. I would say from these, we have all the elements, and maybe I will just add something, just maybe to explain a little bit what are we going through. But I can start saying that as clinician, we also share with you exactly, we also have emotions. And I can tell you, there are some situations where you are so frustrated because you cannot do what you wanted to do. And so I think also our strength is in the fact that being on a different side, but not very far from one each other, we share emotions. And I can tell you that also, pain that you cannot control, bleed that you cannot stop. It's also painful for us. And I can tell you, sometimes even physically painful when you have a child or a patient in front of you, you cannot properly help. So thank you for your experience. And let's try to better understand the environment of this very special group of patients, of people with hemophilia B with inhibitors. I hope you can see my slides now. Okay. And I will briefly go through just summarizing exactly what Dominic told you just from the clinical perspective. So why are we talking about this group of people? Okay, because sometimes, or at least that hemophilia B in general, it's rarer than hemophilia A. So by definition, we know that we have 1 in 10,000 for hemophilia A, and the figure for hemophilia B is 1 in 50,000. So historically, this already led to the fact that we were learning much more for hemophilia A, and because of the rarity of hemophilia B, we already translated what we had as an information in hemophilia A to hemophilia B. And it worked because in the end, when you have severe hemophilia, you have very similar clinical feature. And also the rationale of treatment, it's pretty much similar, because in hemophilia A you give factor 8, in hemophilia B you give factor 9, and it's almost very similar, not really the same, but very similar. But when you go into the inhibitor chapter, the mechanism, it's similar, but the outcome, it's very different under the clinical perspective. And here I just try to summarize why. Because inhibitor development is indeed something pertaining childhood, as Dominic already said, because it is strictly related to the fact that the body of an hemophilia person, this body never saw either factor 8, factor 9, and as soon as it sees for the first time factor 8 or factor 9, the immune system can react towards factor 8, factor 9, producing these antibodies. What happens is that when you have this antibody neutralizes the activity of factor 8, factor 9, which in our case, it's really a problem, because you neutralize the effect of what is therapy in this case. But the difference is that, and yes, antibodies are much more prevalent in hemophilia A than in hemophilia B. But when you have this in hemophilia B, this can be really complicated to manage, because usually antibodies that develops are IgG. It's a special type of antibodies. But if you heard well from Dominic, he told us that he had an anaphylactic reaction. What happens in hemophilia B, which is something that doesn't happen in hemophilia A, is that some type of those antibodies are of a different class, different type called IgE. And these are the antibodies that develops in people who have allergies. And so here we have not only antibodies that neutralizes factor 9, which is already bad, but the fact that these antibodies are also able, not in all patients, but in some of them, they can trigger allergic reaction. So you cannot use factor 9 because it is not effective, but you have also the problem that if for any reason you try to use factor 9 and you have this kind of antibodies, giving factor 9 triggers allergic reaction that can be, as you all know, when you have an allergy to food allergies or allergies, this can be mild reaction, but this can be very severe. This can be life-threatening. So having an inhibitor in hemophilia B can also be very much complicated because of this problem of allergic reaction, anaphylactic reaction. And this also has a very huge impact on the therapeutic side. Why? Because when you have an inhibitor, you usually cannot use factor 9. You should use bypassing agents. Bypassing agents are either factor 7, activated factor 7, or APCC, prothrombin complex concentrate. But APCC, by definition, contains factor 9. So if you have a person with hemophilia B who developed an inhibitor and this inhibitor triggers anaphylactic reaction, you cannot use APCC. So even your therapeutic weapons are much less because APCC contains factor 9, can trigger anaphylactic reaction. So you might appreciate that this is quite complicated. And this also has an impact under the treatment standpoint if we want to try to get rid of the inhibitor, because you might know that when we have an inhibitor, either in hemophilia A or B, we could try to abolish the immune response by doing immune tolerance. Immune tolerance induction, it's something that we use as clinicians to try to, let's say, make the immune system good again and try to educate the immune system to recognize factor 8, factor 9. But the way you need to do that is to give regularly factor 8 or factor 9, in this case, factor 9. And again, if you have someone who developed an inhibitor who triggers anaphylactic reaction, you cannot do ITI, immune tolerance induction. That's why we say that immune tolerance in hemophilia B is far less effective than hemophilia A. Not really because the efficacy is not there, but because you cannot do that because of the risk of anaphylactic reaction. This already I explained that the problem is that when you have factor 9 in a body that was born without, and this is pretty much also related to the type of mutation, the reaction of the immune system is different. And that's why also the type of gene mutation is very important in hemophilia B, because inhibitors, almost all patients with inhibitors in hemophilia B, they have a very large mutation in the gene, which means that they cannot produce anything which is similar to factor 9. And that's why the immune system is so strong in reacting. This is a little bit different from hemophilia A, where some patients, even with different mutation, just because factor 8 is a little bit different, they can trigger inhibitors. In hemophilia B, almost all who develop an inhibitor, they have what we call null mutation. So the mutation that destroys completely the gene, so the gene is not recognizable any longer. And this explains also why having an inhibitor in hemophilia B is much rarer, because these mutations in hemophilia B are much rarer as compared with hemophilia A. Having an inhibitor also means, just saying that someone has an inhibitor is not so precise in definition. As clinicians, we are pretty much interested in knowing how much inhibitor is present in the body, Because when you have something which is below 5 Bethesda units, which is the units that we use to measure, you can still manage with factor 9 if you don't have anaphylactic reaction, of course. So if you have someone without allergic reaction and you have a low titer, so not a huge quantity of inhibitor, you can still manage with factor 9. Under the clinical point of view, is an advantage, of course, because you can still manage well the bleeding. Everything that goes 5 and beyond is not manageable with factor 9. So you should go for bypassing agents. And for bypassing agents, I will show this first. As I told you already, we have two chances, recombinant 7A and APCC, but APCC is, you cannot use APCC in those who have allergic reaction. And generally speaking, when we, as a clinician, when we have to manage bleeding episode in patients with inhibitor, we need to know how much inhibitor is present in that moment, but also if this inhibitor is able to be higher or lower. What I mean is that also the history is very important. And I always say that because you, as the one living with the disease, you should have this information. It's very important because when you enter, you know, it might happen that you have a bleed, you enter a hospital, and believe me, you are the one knowing more many doctors. So if you have just few key information, this might change completely the management. So you know that, as again, Dominic told us already this. He told us that he could use factor 9 after sometimes when the inhibitor went down. And this is important because if you don't experience allergic reaction and you just fall down from the bicycle and you hit your head and you have a chance of an intracranial hemorrhage, and you know that your inhibitor, now it's 1 or 2, you can use factor 9, which is far more effective than using recombinant 7A. Of course, you know that you will have a higher titer, but it will be in 1 week, not immediately. So you have 7 days to completely control the bleed. And then, of course, afterwards, you would need to use recombinant 7A, but the best part of the bleeding control is already over. And the other way around, if you know that now, today, you have 1 Bethesda unit, so very low titer, and you have a mild joint bleed, you should not use factor 9 because in 1 week you may, and if you know that your inhibitor is able to be 10 or 20, because in 1 week you will have 10 or 20, and if then you fall down on the bicycle on your head, you have just recombinant 7A or APCC if you don't have allergic reaction, but no factor 9. So this is how clinicians also think and choose the treatment strategy, not only looking at the current bleeding episode, but also having in mind what would be the reaction of the body and then the consequences in the future to manage future bleeding. For ITI, I already told you that this is less effective because of the risk of allergic reaction. That's why also in some situation, when really we need to get rid of the inhibitor, we tried to use immune suppressive drugs. So those drugs that, let's say, keep silent the immune system. Alone, those drugs are not able to get to abolish the inhibitor production, but together with ITI, they might help because they just, let's say, clean up the blood from the inhibitor and then allow ITI to be effective. These protocols, though, are a little bit a burden because you should use many drugs together. These kind of protocols with immune suppressive drugs, sometimes they need also hospitalization. You cannot do easily at home, so they are not that frequently used. But let's go to then to the management. Nowadays, we have, with the new therapies, the possibility of something that we never mentioned in this talk before, preventing bleeds, prophylaxis. Prophylaxis is the standard of care for hemophilia, for everyone with hemophilia and the bleeding phenotype. Up until we had no new therapies, people with inhibitors, they had no chance to have a good prophylaxis, or at least prophylaxis at all, because there were some attempts in doing prophylaxis with bypassing, but they were not that effective. So the first knowledge of good prophylaxis in patients with inhibitors came with EMI, but it was just for hemophilia A. And recently, thanks to what already Dominic mentioned, first with clinical trial, but now we have those drugs in the market, still not licensed everywhere, but they are coming more and more. And again, our role, I echo what Dominic said, our role is to make it possible for many, everywhere. Whenever it is possible to have access to that, this should become possible. These molecules are molecules similar to emicizumab in their structure, but different for mechanism of action. We have concizumab and marstacimab. They are both monoclonal antibodies, and their role is to bind TFPI, which is a natural inhibitor of coagulation. So in a way, you release the brakes of coagulation. So you make the coagulation more active by inhibiting a natural inhibitor, and this inhibitor is TFPI. They are similar in the mechanism of action, but they have some differences in their profile, how they work in the pharmacokinetic profile. And the difference translates mainly in the fact that concizumab is the one, they are both active in hemophilia A and B with and without inhibitors. But if we look at the practical characteristics, I would say, as the licensing and the approval, as of today, concizumab is approved in some countries only for patients with inhibitors, so hemophilia B with inhibitors, while marstacimab is not approved yet, even though it's effective, could be effective. It's not approved for hemophilia B with inhibitors. And the difference with the pharmacokinetic is that concizumab should be delivered daily with subcutaneous injection, with a pen injector, which is, I mean, I think Dominic can speak better than me, that I didn't try on myself, but I know from patients that is very good, very user-friendly, painless, and I mean, even if it's daily, it's something like having a coffee in the morning, injecting, and that's done. Also because the volume is very, very small. Marstacimab, just to say that, okay, this is not licensed for B with inhibitors, but it could be effective. So maybe in the future, this would be also available. For his characteristics, is injected weekly, always subcutaneously. The other drug is fitusiran. Fitusiran, I just put it here because it exists, but in Europe, and we are here for the EHC, fitusiran by now is licensed in the US and in some other countries, but outside Europe. In Europe, it's still under investigation because EMA wanted more data, because the dosage of fitusiran was changed during the clinical trial, because some thrombotic events occurred during its use. So FDA was fine with some data, let's say less data, to have it licensed. European EMA, so the European agency, asked for a little bit more data with the new treatment schedule, which is the one licensed also in the US. And so, but we are, approaching also the date of licensing of this drug, which is also interesting. It's subcutaneous. Its mechanism of action is interfere with the synthesis, with the production in the liver of another inhibitor, which is antithrombin. So also antithrombin, it's an inhibitor of coagulation. So again, you release the brake of the coagulation, and coagulation works more. And interestingly, the schedule you start with this drug is 1 subcutaneous injection every other month. So if we look at 1 year, prophylaxis with fitusiran is 6 injections over 1 year. So you see, we are moving fast towards something that will allow definitely good prophylaxis. All these drugs are pure prophylactic agent. This is very important to know. So you will use them for prophy. It may happen that you have some bleeds. So bleeds can still occur, much less, of course, because prophylaxis is effective. And in case of bleed, these are not drugs able to control the bleed. So you should not use again, I mean, you should not take another injection of this drug, but you should still rely on bypassing agents, again, recombinant 7A or a PCC, according, to the response and the allergic reaction, so on, so on. But of course, as already Dominic mentioned, the bleeding episode become very infrequent, more manageable, because the background is there and your coagulation is already functioning much better. And so you have less chance to bleed. And I think, yes, I just gave you an overview and we come back to the gallery. Thank you.
Thank you, Maria Elisa, for sharing both your clinical expertise and your personal reflection on the management of this condition. It's a pleasure listening to your talks, as always. And we will now open the discussion. We have around, let's say, 10 to 15 minutes, and I will invite all participants to join the conversation. Please feel free to share your comments or ask questions, as again, this interactive exchange is a key part also of today's webinar. So please do raise your hand if you have questions. Oh, Mirsad did raise his hand. Yes, Mirsad.
Hi, everyone. It's nice again to see you. Dominic, thank you for your presentation. Also, my story seems like that. Also, since a kid, everyone, a patient is diagnosed. But my question to Dr. Maria is that how does the gene therapy contagion to the hemophilia B with inhibitors? Does it can take also their patient, or it has some protocols that or maybe they are not allowed to take them?
Yeah, as of today, gene therapy cannot be offered to people with inhibitors because the presence of inhibitor will somehow spoil the effect of the expression. So as soon as factor 9 is expressed, it's completely neutralized by the antibody. So it will be recognized and neutralized. There are some studies in animal models and trying to understand if a certain type of gene therapy, mainly hiding so making factor 9, let's say, hidden in some cells that could be lymphocytes or platelets, can somehow overcome and overwhelm the presence of inhibitor or even act as an immune tolerance. So the fact that this is expressed can somehow reduce even the production of inhibitor. This has been brought already to clinical investigation for hemophilia A, and it worked yes and no, not really for everyone. As yet, there is no human experience for hemophilia B. So as of today, gene therapy is not prescribed, is not used because of not effective outcome in hemophilia B with inhibitors. So still we need to have to go for immune tolerance, so to get rid of the inhibitor, to think about gene therapy. But for the future, also for gene therapy, there are many new things coming. And gene editing is the next step. And who knows, maybe, having a more stable production of factor 9 in the cells could act as immune tolerance. But it's a matter to try and to try to understand if it works.
Thank you for the answer.
Thank you, Maria Elisa. Does anyone else have a question or a comment? Yes, Jim.
I was just going to ask Dominic a couple of things. Dominic, just for my own interest, what age were you when you first met anybody else who had hemophilia, or especially hemophilia with inhibitors?
So I was, I think, 5 years old, 4 years old, I would say, when I first met a person with hemophilia. Hemophilia B with inhibitors. Phew. Hemophilia B with inhibitors, maybe in Bairdstown. First Bairdstown, I think maybe 2018.
Yeah.
I think I was 17 then.
Okay. And the other question I had for you was obviously with the 17 years of poor treatment and poor lookout for the future, you obviously learned some good coping strategies that have made you now a very positive person and always very good humored. Do you want to share some of the coping strategies with us?
Coping strategies. Good question, Jim. Thank you. So coping strategies. Oh, I think my whole day was a coping strategy. Um, uh, I know for a fact. I was talking to somebody not even hemophilia related, not a doctor. I remember back then I had a lot of pain, and that person told me to imagine pain as a small fire. Close your eyes, imagine pain as a small fire. And then in your imagination, in your mind, try to make it smaller, make it smaller, try to extinguish it. I know that helped me a lot. I used that for years and years when I was in big pain. There's a million of methods for specific bleedings that I learned how. For example, shoulder bleeding. Shoulder bleeding is one of the worst ones. For me, it was. It hurt like, I don't know, I'll just say it hurt like a beep, Um, so I wrapped my hand in the thing you cover yourself with on the bed. And I put my hand down so it falls from the bed, and so it's levitating a bit, wrapped in the sheet. That's the word I'm searching for. So that, and generally just staying positive, staying positive helped me a lot. When I was surrounded by negative emotions, problems, specifically outside of hemophilia, somehow I think that I always bled more. And I remember the theory I thought of when I was 16. So I had a severe bleeding in my right elbow, and I was 16. I wanted to go out with my friends. So usually those kind of bleedings lasts for 6 to 10 days for me. And I went to the hospital because my mother didn't allow me to go anywhere before that. She insisted. I didn't want to go. I have to acknowledge that. Yeah. She made me go. I got brownilla in my vein, and I got my factor 7. And the same day, with severe pain and severe bleeding, I went out to a friend's birthday. And I was in pain. I kind of wanted to hang out, didn't want to hang out, and I just said, let's stop this. I got the medication. I just need to relax a bit. I just need to think about something else. I cannot think about this anymore. And it hurt a lot, but I felt alive. I felt really good. And I came back at 3 a.m. Tomorrow morning I could extend my arm. The swelling, it came down. And I was amazed. I was really surprised. I couldn't believe my eyes. I couldn't believe what I feel. When that happened for five times in my life, I somehow connected those dots, and there is something in it. I would say there is something in it. So those are the things I would say helped me a lot to manage hemophilia.
Thanks, Dominic. I think you've given us a whole new idea for a brand new webinar just on coping mechanisms.
Well, feel free to call me.
Thank you. Thank you both. If no one has any question, I wanted to just briefly ask Maria Elisa, we have a couple of more minutes. You've mentioned, Maria Elisa, that marstacimab, for instance, is effective for hemophilia B with inhibitors, but is not licensed for that kind of treatment. Or, for instance, concizumab is effective, and we can see that it's it's not resolving completely the issue, again, when it comes to acute bleeding, but again, it's helping a lot in managing the disorder and the symptoms. So what can we do as patient organization or as a community together with clinicians to affect the policymakers to speed up the processes? As again, when it comes to concizumab, unfortunately, it's still unavailable in many of the countries. I don't know if it's financial nature, the reason, or some other, but again, what can we do from our side?
So, the problem, it's yes or no financial, is pretty much related to the rarity of the condition, of course, because yes, we are talking about, if you think that 1 in 50,000 hemophilia, and then in the worst scenario, you have 10% with inhibitors, it's really very, very rare. So this, of course, it's something that in some situation, of course, in some context, make this drug maybe, just for in the policymaker horizon for 1-2 people. And of course, we are here to say that even for one, these matter. So I think that the activity of, raising awareness and raising awareness on the fact that those people, they exist in Europe. So the vision should be really broad there. It's not country by country. It's something that should go supranational to me, this kind of, so we should try to find a way to extend availability beyond just country boundaries. This is, of course, we should comply with some rules, but there should be a way to even, claim for very rare disease. And hemophilia B with inhibitors, it's something which is really very rare. So this cannot be just considered a variant of hemophilia B, for which we have factor 9. This should be really very, and so raising awareness either from, clinician perspective, so medical perspective together with patient perspective has a role. And, even, I think in some situation we should also consider to involve industry in terms of giving the drug. In some special situations, some donation could also help in terms of compassionate use, because you can then start using, demonstrate that it's really helpful and that life changes, as Dominic showed us very clearly. There is no doubt there. And in that way, then push the fact that this that has been firstly donated needs to be procured because it's useful. So I think it's step by step. And of course, again, collecting data. So data in terms of how many people we have with this condition. Because of course, speaking for one, we can be vocal even for one, we must be vocal even for one. But if we know that they are 10, 20, or 30, of course, it's much better in terms of advocating for such drugs.
Thank you so much. You gave us something to think about. So if there are no further questions, I'm afraid we are out of time. I want to thank you all for your contributions and thoughtful questions. A special thank you to both of our speakers for their openness and expertise. Today's discussion has highlighted the complexity of managing hemophilia B with inhibitors, while also underscoring the importance of collaboration between patients, clinicians, and the wider community. So I encourage you to continue these conversations beyond today's webinar and to remain engaged with the work of the EAHC and EAHAD as we collectively strive to improve care and outcomes for people living with this condition. So thank you all once again for joining us, and I wish you all a very pleasant evening and a wonderful weekend ahead.